Every single day, people over 40 walk into a doctor's office with knee pain. They get an X-ray. The doctor points at the screen, says the word arthritis, writes a prescription for anti-inflammatories, and tells them to lose weight. Appointment over. The patient walks out believing their knee is deteriorating, and there is nothing to do about it except manage the decline. 15 years of clinical practice. I have seen this exact sequence hundreds of times, and in the vast majority of those cases, the diagnosis was wrong. Not completely fabricated. The X-ray may genuinely show some cartilage wear, but mild cartilage wear after 40 is like wrinkles on your face. It is there, it is normal, and it is almost never the reason you are in pain. Here is what nobody investigates. Where is the pain actually coming from? Because the knee is one of the most commonly misblamed joints in the human body. The pain is real. Nobody is questioning that. But the source of that pain, the structure that is actually inflamed, compressed, or overloaded, is frequently not inside the knee joint at all. It is above it or below it. And when you treat the wrong source, you do not simply waste time. You let the real problem quietly get worse while your attention is pointed in the wrong direction. The system is not built to dig deeper. A 12-minute appointment does not leave room for a biomechanical investigation. A pill is faster, a referral is easier, and the patient leaves thinking this is just what happens when you get older. It is not, and that belief is the most dangerous part of the whole cycle. Subscribe and hit like right now. What you are about to hear, nobody is going to explain at your next appointment. The system profits when you stay on medication, not when you find the actual cause. To understand why your knee takes the blame for problems it did not create, you need to see how it is built. Most people picture the knee as a simple hinge. It bends, it straightens. That is it. That picture is dangerously incomplete. Your knee is a crossroads. Muscles from your hip attach across it. Tendons from your thigh wrap around it. Ligaments anchor it from every direction. A thick band of connective tissue runs from your outer hip all the way down past the knee to your shin. The calf muscles below pull on it from underneath. The knee does not operate independently. It is caught in the middle of a web of forces coming from above and below. This is why orthopedic specialists call the knee a victim joint. It rarely creates its own problems. It suffers the consequences of problems that started somewhere else. Think of a rope bridge strung between two cliffs. If one cliff shifts, the bridge twists. You look at the bridge and say it is failing, but the bridge is not the problem. The foundation moved. That is your knee. The hip above it or the ankle below it malfunctions, and the knee absorbs the punishment with every single step. True, cartilage-driven arthritis severe enough to produce daily pain is far less common than most people have been led to believe. The real culprits, muscular imbalances, fascial tension, referred pain from the hip, are mechanical errors, and mechanical errors are correctable. By the way, if you are dealing with knee problems or any joint issue, and you want to see what new options are actually out there right now, Care Health is the link on my channel page. A lot of you have already checked it out. Now, back to your knee. The first culprit I look for when a patient walks in with knee pain is not in the knee. It is in the hip. Specifically, a muscle called the gluteus medius. That is the muscle on the outer side of your hip, and its primary job is to stabilize your pelvis every time you take a step. When your right foot leaves the ground, the left gluteus medius is what keeps your pelvis from dropping on the right side. It fires thousands of times a day without you ever thinking about it, or at least it should. Here is the problem. Modern life has trained this muscle to shut off. You sit at a desk for 8 hours, you sit in a car, you sit at dinner, you sit on the couch. During all of those hours, the gluteus medius is completely inactive. It is not stretching, it is not contracting, it is doing nothing. And over months and years of doing nothing, it essentially forgets how to activate. Physiotherapists have a term for this: gluteal amnesia. The muscle is physically there, but neurologically it has gone to sleep. Now watch what happens when you walk. Your foot hits the ground and the glute medius is supposed to stabilize the pelvis. It does not fire. The pelvis drops. When the pelvis drops, the thigh bone angles inward. When the thigh bone angles inward, the knee collapses toward the midline. Every single step, the inner compartment of your knee joint gets loaded at an angle it was never designed for. Thousands of steps a day, all grinding the same spot. Week after week, month after month. You go to a doctor, they x-ray the knee. They see wear on the inner compartment. They call it arthritis. It is not arthritis. It is a sleeping muscle, one joint above the pain. The second culprit lives deep inside your pelvis, and most people have never heard its name. It is called the psoas. Right next to it sits a muscle called the iliacus. Together they form your primary hip flexor group, the muscles that pull your thigh upward toward your chest. Every time you sit down, these muscles shorten. Every time you stand up, they are supposed to lengthen back out. The problem is that they do not get the chance. If you sit 8 to 10 hours a day, your hip flexors spend the vast majority of their time in a shortened position. Over weeks and months, they adapt to that shortened length. They become permanently tight. And a tight hip flexor does not just affect the hip, it tilts your entire pelvis forward. Here is the chain reaction. When the pelvis tilts forward, the angle of the thigh bone relative to the knee changes. The kneecap, which normally glides in a smooth groove on the front of your femur, starts tracking off center. Instead of sliding cleanly, it grinds against the outer ridge of that groove. Every step, every staircase, every time you bend down to pick something up, the pain is sharp. It burns at the front of the knee, directly behind or around the kneecap. Patients describe it as a hot, grinding sensation that gets worse with stairs and squatting. Doctors see that pattern and write down patellofemoral syndrome or early arthritis. The actual cause is a tight muscle in the hip that nobody examined. There is a simple test that reveals this in 30 seconds. It is called the Thomas test. You lie on the edge of a table, pull one knee to your chest, and let the other leg hang. If the hanging thigh rises above the table instead of resting flat, your hip flexor on that side is short. That short muscle is pulling your knee out of alignment every time you move. The third culprit is the one people pay the least attention to. It is underneath you right now, your feet. Most people never think about their feet in connection with knee pain. They assume the knee is an isolated problem, but the knee sits directly on top of the lower leg bone, the tibia, and the tibia sits directly on top of the ankle and the foot. Whatever the foot does, the tibia follows. Whatever the tibia does, the knee absorbs. Here is what happens with age. The muscles and ligaments that hold your foot arch in place gradually weaken. The arch begins to drop. This is called acquired flat foot, and it is far more common after 40 than most people realize. When the arch collapses, the foot rolls inward. The medical term is overpronation. And when the foot rolls inward, it drags the tibia with it. The tibia rotates internally. That internal rotation torques the knee joint with every single step you take. You are not walking on a damaged knee. You are walking on a collapsed foundation, and the knee is paying the price for it. There is a 10-second way to check this at home. Pick up a pair of shoes you have been wearing regularly. Flip them over. Look at the soles. If the inner edge of the heel is worn down significantly more than the outer edge, your foot is collapsing inward. That uneven wear pattern is a direct record of the rotational force your knee has been absorbing for months or years. This is not a disease. This is not degeneration. This is a mechanical error. And mechanical errors have mechanical solutions. Proper arch support, shoes with structured heel counters, and in some cases a corrective insole can reduce that inward rotation and take the torque off your knee almost immediately. The fourth culprit is one most doctors never mention, and most patients have never heard of. It is called the iliotibial band, or IT band for short. It is not a muscle. It is a thick, dense strip of connective tissue, fascia, that runs from the outer edge of your hip all the way down the outside of your thigh to just below the knee, where it anchors into the shin bone. Here is what makes the IT band different from everything else we have discussed. Muscles can stretch. Muscles can relax. Fascia does not work that way. When the IT band becomes tense, it stays tense. It does not release on its own. And when it is tight, it behaves like a guitar string that has been wound one turn too far. It pulls across the outer side of the knee with constant, unyielding force. Now picture what happens when you walk. Every time your knee bends and straightens, that tight band snaps across a bony prominence on the outside of the joint called the lateral femoral condyle. Bend, snap, straighten, snap. Hundreds of times per walk, thousands of times per day. The pain is sharp, highly specific, and located on the outer side of the knee. It often appears after a certain distance and gets worse the longer you walk. Patients point to it with one finger. Doctors examine the knee, see the location, and frequently label it lateral compartment arthritis. It is not arthritis. It is a tight strip of fascia being pulled taut by weak glutes and poor movement patterns above. The IT band itself is not the problem. It is the victim of the same upstream failures we already covered. Targeted hip strengthening restores the balance. Foam rolling along the outer thigh reduces the tension. In most cases, the knee pain on the outer side diminishes significantly within a few weeks. No pills, no injections, corrective work on the structures that created the tension in the first place. Now I need to tell you something that may directly contradict what your doctor recommended. The anti-inflammatory pills you are taking for your knee pain are not helping you heal. In many cases, they are actively preventing it. Here is the paradox. Ibuprofen, naproxen, and other NSAIDs work by blocking inflammatory chemicals in your body. That reduces swelling, that reduces pain, and that feels like progress. But inflammation is not a malfunction. Inflammation is your body's repair crew arriving at the site of damage. Those inflammatory chemicals you are blocking are the same chemicals that stimulate cartilage repair, recruit healing cells to damaged tendons, and increase blood flow to injured tissue. When you suppress that process with a daily pill, you are sending the repair crew home before the job is finished. Published research shows that chronic NSAID use can slow cartilage regeneration, weaken tendon structures, and over time produce thinner, more vulnerable joint tissue than you started with. The pill makes the knee feel better today and makes it structurally worse over months. But there is a second problem that is even more dangerous. Pain is information. It is your body telling you that a specific movement is loading a specific structure incorrectly. When you silence that signal with medication, you keep walking with the same collapsed arch, the same dead glute, the same tight hip flexor. The mechanical error continues, the damage accumulates, and because you feel no pain, you have no reason to investigate. The cycle is predictable. Pain, pill, feels better. Same movement pattern, more damage, more pain, stronger pill. Repeat until the joint is genuinely destroyed, and now you actually do need surgery. Pain is not the enemy. It is the diagnostic tool your body is handing you for free. The goal is to decode the signal, not silence it. You now know the 4 mechanical culprits behind most knee pain: dead glutes, tight hip flexors, collapsing arches, and a tense IT band. The question is, which one is driving your pain? Most likely it is not just one, but you can find out at home in about 3 minutes. No equipment, no appointment. Test 1, the single leg stance. Stand on one leg for 30 seconds. Have someone watch from behind, or film yourself. Watch the hip on the side of the lifted leg. If that hip drops downward, your gluteus medius on the standing leg is not doing its job. It is not stabilizing your pelvis. Every step you take, your knee is collapsing inward. That is culprit number 1 confirmed. Test 2, the Thomas test. Sit on the edge of your bed so your tailbone is right at the edge. Lie back, pull one knee to your chest, and hold it there. Let the other leg hang freely. Look at the hanging thigh. If it rises above the level of the bed instead of resting flat or dropping slightly below, the hip flexor on that side is short. That short muscle is tilting your pelvis and grinding your kneecap off track. Culprit number 2. Test 3. The shoe sole check. Grab a pair of shoes you wear regularly. Flip them over. If the inner heel is worn significantly more than the outer heel, your foot is collapsing inward and rotating your knee with it. Culprit number 3. Test 4. The IT band palpation. Sit down, find the outer side of your thigh just above the knee. Press firmly with your thumb along that band of tissue. If it is exquisitely tender, sharp pain under moderate pressure, your IT band is tight and snapping across the knee. Culprit number 4. Most people will find at least 2 of these positive. That combination is your answer. Not arthritis. Mechanical errors, stacked on top of each other, driving pain into a joint that is caught in the middle. You have identified your culprits. Now you fix them. What I am about to give you is not a workout. It is a corrective protocol. The goal is not to build muscle for the sake of fitness. The goal is to restore the mechanical balance around your knee so that every step you take loads the joint the way it was designed to be loaded. 3 time slots, less than 15 minutes total across your entire day. Morning, glute activation, 5 minutes. 2 exercises. First, clamshells. Lie on your side, knees bent, feet together. Open the top knee like a book while keeping your feet touching. You should feel the burn deep in the side of your hip, not in your thigh. 15 repetitions each side. Second, lateral band walks. Place a resistance band just above your knees. Stand in a slight squat and step sideways, keeping tension on the band the entire time. 10 steps each direction. That is it. 5 minutes. Your gluteus medius is now awake and ready to stabilize your pelvis for the rest of the day. Midday, hip flexor stretch. One stretch held for 90 seconds per side. Step into a deep lunge, back knee on the floor, and gently shift your hips forward until you feel a deep pull at the front of the back hip. Here is the critical detail. Stretches held under 60 seconds produce temporary relief. The tissue springs back within minutes. Research on connective tissue shows that sustained holds of 90 seconds or longer produce lasting structural change in muscle length. This is the difference between feeling loose for an hour and actually correcting the problem. Evening, foam rolling. 3 minutes. Roll slowly along the outer thigh from hip to just above the knee. Then roll the front of the thigh, the quadriceps. Slow, deliberate pressure. When you find a tender spot, stop and hold for 20 seconds. This is not fitness, this is maintenance. The way you brush your teeth to prevent decay, you do this to prevent joint destruction. The corrective protocol restores balance. But if you walk out the door and move the same way you always have, you are reloading the same errors onto a joint that just started to recover. 2 activities cause the most knee pain in daily life: walking and stairs. Both can be fixed with small, deliberate adjustments. Walking first. Most people overstride. They reach the front foot far ahead of the body and land hard on the heel with a nearly straight leg. That extended leg acts like a rigid pole, and the impact travels straight up into the knee. Shorten your stride. Your front foot should land closer to your body, almost underneath you. This keeps the knee slightly bent at contact, which allows the muscles of the thigh to absorb the shock instead of the joint cartilage taking the full hit. Second, engage your hips. Push off from the back leg using your glutes rather than pulling yourself forward with the front leg. This single shift moves the workload from the knee to the strongest muscle group in your body. Stairs are where the real damage happens, specifically going down. Watch how most people descend a staircase. They step forward, let their body weight drop straight down onto the front knee, and catch themselves at the bottom of the step. That is a controlled free fall. The force through the knee joint during that landing reaches 3 to 4 times your body weight. For a 180 pounds person, that is over 600 pounds of force through one knee, step after step. The fix is a hip hinge. Instead of dropping straight down, lean your torso slightly forward and push your hips back as you lower yourself. This engages the glutes and hamstrings to control the descent. The muscles do the braking instead of the joint. That simple shift in technique can cut the force through the knee nearly in half. Your knees do not wear out from use, they wear out from misuse. Correct the pattern and the joint can last decades longer than you have been told. I want to be honest with you, everything I have covered so far applies to the majority of knee pain cases I see in my practice, but not all of them. There are cases where the cartilage damage is real, advanced, and genuinely responsible for the pain. You deserve to know what that actually looks like so you can tell the difference. True, advanced osteoarthritis has a specific clinical signature. First, persistent swelling. Not swelling that appears after a long walk and goes down overnight. Swelling that is present when you wake up and stays throughout the day. The knee looks visibly larger than the other one, consistently. Second, crepitus. That is the grinding, crunching sensation you can feel and sometimes hear with every bend and straighten, not an occasional pop or click. A continuous mechanical grinding that happens with every single movement of the joint. Third, morning stiffness lasting longer than 30 minutes. With mechanical pain from the culprits we discussed, stiffness loosens up within a few minutes of moving. With genuine arthritis, the joint remains stiff, resistant, and painful for half an hour or more before it begins to cooperate. Fourth, imaging that shows significant joint space narrowing. Not mild wear, not minor roughening. Actual loss of the space between the bones where cartilage used to be. If all 4 of those are present, you are likely dealing with structural arthritis. But even then, the corrective protocol from Chapter 9 still matters. Muscular imbalances are almost always layered on top of structural damage. Correcting them reduces the abnormal load on the joint and meaningfully decreases pain, even when the cartilage is compromised. And here is something worth knowing. Treatment approaches for joint conditions are advancing faster right now than at any point in the last 2 decades. Staying informed about what is emerging is not optional. It is part of taking control of your joint health. Everything I have given you today, the self-assessment, the corrective protocol, the movement fixes, that is your foundation. It costs nothing, and it works. But I also know that some of you watching this are past the point where exercises alone are enough. Your knee has kept you from playing with your grandchildren. It has stolen your sleep. It has taken away walks you used to love, and you have been told your only options are pills that mask the pain, or a surgery you are not ready for. What most people do not realize is that right now, across the United States, there are clinical research programs actively looking for people with knee pain, joint inflammation, and mobility problems. These are not experimental gambles. They are structured, physician-supervised programs exploring advanced treatment options, some of which are not available to the general public yet. Participants receive thorough medical evaluations, detailed imaging, specialist care, and close monitoring throughout, often at reduced cost or no cost at all. Care Health is a platform I have linked on my channel page that connects you directly with these programs based on your condition and your location. You enter a few basic details, your name, your zip code, what you are dealing with, and it matches you with active studies near you. It takes 30 seconds. I need to be straightforward. This is currently available to U.S. residents only, and these programs have limited capacity. Thousands of viewers from this channel have already signed up, and spots in certain areas are filling up fast. Once a study reaches its enrollment cap, the door closes. That is not a sales tactic. That is how clinical research works. If you are on a computer, click my channel page, and you will see the Care Health link right there. If you want to go faster, take out your phone, open your camera, and point it at the QR code on screen. A link will pop up. Tap it, and it takes you straight there. If you are watching on your phone, tap my channel profile picture at the top of this video. It takes you to the channel page where you will see the link. A screenshot is appearing on screen right now showing you exactly where to find it. Do not sit on this. I have watched too many patients wait until the pain became unbearable, and by then the programs that could have helped had already closed enrollment. You have the information. Use it while the window is open.